Welcome to the Emerging Scholar Podcast, Season 1. We hope you enjoy this series of great conversations with leading medical researchers that's designed for graduate students, medical trainees, residents, and fellows to help you on your journey towards your first scientific project. Welcome, everyone, to Episode 9 of the Emerging Scholar Podcast. This is the first of two episodes that we're going to be having with Dr. Robert Platt. Dr. Robert Platt is a professor in the departments of Pediatrics and Epidemiology, Biostatistics, and Occupational Health at McGill University. He's a senior investigator at the Research Institute of the McGill University Health Center and the Lady Davis of the Jewish General Hospital. He's also an investigator at the McGill Pharmacoepi Research Unit and holds the Albert Behringer Endowed Chair in Pharmacoepidemiology. Dr. Platt is not only one of Canada's leading experts in pharmacoepidemiology, he's also one of the early adopters and leading experts in causal epidemiology. So this is the first of a two-part series and the third of our epidemiology series, where we have gone from descriptive epi to predictive epi, and now we're going to talk about causal epi and the assumptions that come along with that. Dr. Platt has applied these in different situations and has been one of the Canadians to pioneer one of the emerging methods called target trial emulation. So we're going to talk a little bit about what target trial emulation is and walk through one of his more recent papers where they applied that to try to understand a question around pharmacoepidemiology as it pertains to maternal and child health. Dr. Platt is an outstanding educator and describes these complex causal inference methods in a really good way. It really helped me refine my understanding of this area, and I hope that it helps you too. Welcome, everyone, to the Emerging Scholar Podcast. My name is John McGavick. I'm the host today, and it's my great pleasure to have Dr. Robert Platt from McGill University, who's here with us to talk about causal inference. Welcome, Dr. Platt.
Hi, thanks for having me.
All right. A number of people have suggested we reach out to you to give us sort of the intro to what causal inference is. And looking at your CV, it looks like you were one of the early adopters here in Canada for bringing causal inference into epidemiology, biostats, with an interest in perinatal epidemiology. So I'm really excited to have this conversation. Tell us where you got started on this and what was your journey from sort of grad studies to where you are now?
So first of all, I'm happy to be on this call. I grew up in Winnipeg and did my undergrad training at McGill, then went to University of Manitoba for a master's degree, then to the US for a while. Then I found my way back to Montreal in the late 1990s, working at the Montreal Children's Hospital as an applied statistician, and started to get more involved in leading some research projects around the late 90s. And then once I switched on to the tenure track at McGill, I was doing a lot of reading of papers coming out, mainly from Jamie Robbins's group at Harvard, trying to understand what they were doing. It was around that time that they developed the marginal structural model, which is one of the sort of core tools I've worked with and over the years. And I spent my first sabbatical with just a pile of papers and said I was going to learn as much as I can about this stuff.
Oh, right.
That was in 2004 or so. And so it was a nice time to just really dive in and learn as much as I could. And then I got quite interested, had a couple of students who got motivated to start thinking about these problems, mainly from a statistical methods perspective. And we wrote a few papers and developed a course, and it sort of went from there. It's been a large part of my career since the mid-2000s.
Right on. So for those of us that know more of the descriptive epi or the traditional association studies where, you work a lot with large administrative data sets, in those data sets, we would say, I want to study an association between breastfeeding duration or breastfeeding exclusivity and body weight throughout infancy, for example, right? We would traditionally run a series of regressions or do associations, right? How would you describe the move towards trying to infer a causal association between an exposure like, let's say, breastfeeding and infant BMI? What are sort of the key differences between that traditional approach and the more causal approach?
The first principle I would think about in thinking about whether we're inferring causation, and I'm going to probably spend most of our time today talking more at an almost philosophical level than an analytic level about this. But the first thing I would do is conceptualize the thing that you want to study as a hypothetical experiment. And I'm choosing my term carefully there, saying a hypothetical experiment, because I don't want us to get bogged down in the headaches and the issues with actually conducting a randomized trial of something like a breastfeeding promotion intervention like Mike Kramer did. I want to think about conceptually, could we just do an experiment where we randomize people to breastfeed or not? And that's, of course, completely hypothetical. We can't do that, but we can conceive of it. And Jamie Robbins and Miguel Hernan, following on some earlier work of Robbins's and some earlier work of Don Rubin and colleagues, helped frame this idea of a hypothetical randomized experiment where you're saying, okay, what would happen if we randomized people to, say, extended breastfeeding versus early weaning? And that's a well-defined conceptual thing that, again, is impossible to do. But if we start with that, we can think of how in that sort of hypothetical perfect experiment, the only thing that's changed between the people who initiate and then breastfeed for longer term versus wean early, the only thing that's different between them is the breastfeeding. And so therefore, assuming our samples are large enough and we get clear enough distinction between groups, we're not worried about things like statistical power, we can infer that any differences between the groups must have been caused by the fact that one group was assigned to breastfeed longer and one group was assigned to wean earlier. So if we start with that conception, and there's some very nice work, again, by Hernan and Robbins, I would recommend that almost anyone who has a basic understanding of epidemiology statistics read their book called What If? It really covers this from a very basic level up to a much more heavy analytic level. But I would also go back to an earlier paper by Paul Holland, which is in the Journal of the American Statistical Association in 1986. It's a statistics paper, but it's probably the easiest read in JASA that has ever been written. It's mostly conceptual about this idea of a hypothetical experiment and then what can you do with that. Given that, it's now a matter of saying, can we take our observational data and map it to that hypothetical experiment? Could we recreate that experiment using observational data? And we have to go through a number of steps and a number of assumptions to get there.
Yeah, so assuming you've got that data with you, you would not go in and say, what is the traditional way to analyze this data? You know, let's look at other papers and see how they've done the analysis, and we're just going to try to replicate that, doing it a little bit different. You come in with a different frame and say, okay, can we recreate a randomized experiment using this data? But before you went to do your sabbatical, you must have been thinking, I want to do something different, and I'm going to go for a deep dive into this causal inference methodology or literature and see how I can apply it. And why did you want to make that jump? What got you sort of passionate about bringing this also to the next generation of students coming through McGill?
So that's a good one. I think there were a few things, and some of it had to do with some of the early work that I did with Michael Kramer in perinatal epi, where we were having discussions along these lines independent of the literature about saying, when we were thinking about perinatal exposures, things that happen, say, during pregnancy and how you analyze the effects of them, we had been having these conversations about, okay, what kind of trial would we have done? And when comparing that to some of the stuff that was in the literature, it raised questions for us that made us think, okay, maybe we should think about doing things differently. I guess parallel to that, I was also working on some statistical research on longitudinal data where you follow the same people over time and maybe their exposure changes over time. It was in that area where Robbins's work in particular sort of made the biggest paradigm shift. And he had some papers in the late 1990s, early 2000s, where he gave you striking examples where if you use the methods that the sort of standard analytic methods that I thought of as, cutting edge best practice, if you use those methods to answer this kind of question, you're going to get the wrong answer. Not just a little bit wrong, but maybe a protective effect is going to look like a risk or something to that level, the sign of the parameter flipping. And between those things, those set of conditions were really compelling to say, okay, I need to understand whether these methods are magic or whether there's some real fundamental conceptual issues underlying them. And I think I had a bit of a circuitous route through deep into some of the analytic issues with my work, but it really comes down to this: could you conceptualize a trial or an experiment that you could have done? And I'm sure some of the listeners have heard a lot of the work in the epidemiology literature these days is talking about the target trial framework. framework, where you take a very explicit step-by-step way of doing this conceptual exercise that I described before you run your study. And to my mind, those are very, very closely linked concepts that you're really sort of in the target trial framework, you're setting the groundwork so they can make causal inferences from observational data.
Right. So just to summarize, you've got an in utero exposure that you're interested in studying. You're trying to look at it and say, what if this was an experiment? And man, these analytical approaches, that's not going to work. And two, even if we do apply it, we could get the total wrong answer here. So I need to completely think about this. And you're the expert, right? The clinician's coming to you for advice. And there must be a little pressure on your shoulders to say, okay, I'm going to give you the best advice and we're going to tackle this the best way, right? Michael Kramer's leaning on you and your expertise to nail this, right? So you're like, I got to do a deep dive on this and then see how we can apply it. Do you have an example? Like, what was your first study where you started to apply these methods?
So actually, I think I'll go back to, and it probably is the first study we tried to do this with, was Mike's promotion of breastfeeding intervention trial, or PROBIT is the acronym he used for it. And this was a trial that they started before I got to McGill. It had started in the early 90s of a breastfeeding promotion intervention in Belarus, conducted it was a cluster randomized trial. So they had 30 odd hospitals in Belarus. Half were randomized to this promotion intervention. The other half were randomized to usual care. And then they looked at the differences in outcomes between kids in the promotion intervention hospitals and the kids in the control hospitals. And because it was a randomized trial and because they controlled for all kinds of other things through randomization and design, they were able to infer that the promotion intervention did this or it did that. And some examples are it seemed to strongly prevent gastrointestinal infections. It had, if I remember correctly, relatively limited effect on respiratory infections. These are both in the first year of life. And that was a landmark study because breastfeeding is very hard to study in general, just because it's confounding of breastfeeding is very complicated. And it's hard to imagine an experiment where you could randomize people to breastfeed or not, just because the decision-making process for breastfeeding is fairly deeply it's complicated and it depends on a lot of personal and social factors. So that study was, again, a landmark, really important. And we started asking ourselves the question, could you get at the causal effect of breastfeeding itself from that study? And we had data on breastfeeding over the first year of life and on the baby's weight over the first year of life. And one of the things we wanted to see was, could you untangle that effect of breastfeeding on the act itself rather than the intervention on the baby's weight? And that led us to thinking about, because breastfeeding is a longitudinal exposure and the weight is a continuous outcome, that led us to think about the exact setting I was talking about earlier, where Robin says, if you do this wrong, you could get the completely wrong answer. And that was probably the thing that got us thinking first about how to do this. And that led us to some methodological things we had to think about, because we had to tweak the problem a bit on the analytics side to get it to work well. And I think Mike and I published a couple papers on that. It led to some methodological work as well. And then Erica Moody published another paper, another Winnipegger who's at McGill in the Department of Epi and Biostat, published another paper on her area of interest, which is another sort of offshoot of the causal inference methods. And that study probably really was the one that motivated me to get thinking about this. Lately, now that I'm working on pharmacoepidemiology primarily, this idea of the hypothetical experiment has become more ingrained in my thinking and more important, because I'll give an example from a paper that we have that is coming out fairly soon. Levothyroxine is given for subclinical hypothyroidism, and it's a very important drug that works well to treat subclinical hypothyroidism. This often appears during pregnancy, and so a woman might become pregnant, develop the condition, and start taking levothyroxine in, say, the 14th week of pregnancy. Ideally, you'd like to know using the randomized experiment paradigm, you'd like to know, well, what would have happened to that woman and her baby if she didn't start in the 14th week of pregnancy? You want to go in, and this is oversimplifying a little bit, but still the idea of the methods that we're talking about is to go in and find someone else who looks like that woman with the same characteristics, the same history to the best of your knowledge, who didn't get levothyroxine at 14 weeks.
Yeah.
Then you can compare those two going forward. And that is close as you can get to that hypothetical experiment that I started with at the beginning. And that's really important. And it's fairly easy to show that if you just compare women who get levothyroxine to women who don't, you run into trouble because of a phenomenon called immortal time bias, where you have to survive long enough, or the baby has to survive long enough for you to get the drug, and all earlier miscarriages or stillbirths are effectively assigned to not getting the drug because they weren't alive long enough to get the drug. So you can really get the wrong answer if you do it with a sort of a traditional association study, primarily because you're not aligning that start point of the drug with the start point of someone else who is a comparable person.
In my understanding, that's the key for that target trial emulation, right? Is that starting point has to happen. So let's start with an example here. I'm interested in gestational diabetes, for example. I'm a resident and my advisor is an adult endocrinologist, and we've got this huge data set here in Manitoba Center for Health Policy. I'm interested in treatment of gestational diabetes with metformin, with insulin, or with something new that's coming out, a GLP-1. And we've got all this data, right? So now I'm coming to you and saying, okay, well, let's just compare these, either the women long-term or the offspring long-term, and see which drug does better for preventing diabetes in the kids or preventing subsequent diabetes in the mom. Where do I start with this question if I want to tackle it from a causal perspective?
That's a really good question, and an important one, and a challenging one. And I would probably start with simplifying the problem to say, okay, let's think about metformin versus insulin, or metformin versus GLP-1, or metformin versus
nothing, lifestyle,
diet and lifestyle. The more treatments you try to compare at the same time, I don't think it adds complexity down the line, but it just gives us more to talk about in the short run. So it's easiest to just say, let's talk about metformin versus GLP-1, say.
Also a good teaching lesson for residents, right?
Yeah, simplify as you start.
Keep it super tight. All right, so do we start with imagining what the trial would look like, or do we start, you and I talked earlier about DAGs, do we start drawing a DAG, for example?
So I think I would probably do both concurrently, because what you'd like to do, and let's say we could envision a trial or an experiment, and we think about pregnant people diagnosed with gestational diabetes who are then, and I mean, it's very easy to think about, you could, if you had millions of dollars and lots of time, conceptualize an RCT there and really think about doing one, but that's not going to happen. And you have data on people who've taken both metformin and GLP-1. So you first of all say, let's establish a cohort of diagnosed with gestational diabetes, and then let's look for who initiated metformin and who initiated GLP-1s, and hope that the time window in which they initiate the drugs is relatively narrow so that we can think about a single clean target trial of you're diagnosed and then you initiated A or B.
So the window of time is between using the administrative data. We know you were diagnosed with gestational diabetes in this month, right? Or at this week of gestation, right? Mm-hmm. It's not going to be month, it's going to be week of gestation. And then there's someone who's very similar to you who was also given a medication at this week of gestation. And those two are really comparable.
That's ideal, yes.
Okay.
That's the ideal scenario. And then let's say we have that, then it would make sense to say, okay, in effect, let's draw a DAG to say, and what we really want to know about when we're saying we're drawing a DAG are primarily, what are the confounders? What are the things that could affect my outcome, whatever that is down the line, and affect the decision to take metformin versus GLP-1? And so, you'd run through a long list of things, maybe the seriousness of the gestational diabetes, maybe the
access to it,
access to the care, maybe weight, maybe pre-existing conditions. You'd want to think about what are your inclusion-exclusion criteria, which don't necessarily fit into your DAG, but fit into the target trial conception of saying, okay, who do I not want to study? So I don't want to study this question in people who have previous evidence of having type 2 diabetes, for example. I probably want to restrict this question to newly diagnosed gestational diabetes. And then I want to think about the confounders. And then I want to think about, at least potentially, what is the cascade of outcomes that I'm looking for. So in case we were wanting to think about down the line, and this is for an entirely different, more complicated discussion, mediation kind of problems. Yeah. Like if you want to know if something's happening to the kid, whether it was mediated through something that happened as part of the pregnancy, you want to start establishing your DAG to cover those kinds of things. So you kind of then want to spend some time thinking about what the variables that you would need to control for in your study are. And then obviously you've got to go back and say, okay, do my administrative data or my registry contain enough of these variables that I can do something with it? And at that point, and this is somewhat to my chagrin as a statistician, but somewhat to my relief as a statistician, if you get to that point and you don't have one of these problems where you have a longitudinal exposure, then the analytic method that you choose matters relatively little. You can get fairly similar answers from a lot of different methods. If you are interested then in, say, sustained use of metformin or cumulative use of metformin versus sustained or cumulative use of GLP-1s, then you've got to start thinking about something like a marginal structural model or one of the other tools that Robbins and Hernan and others developed to actively address these longitudinal questions.
So let's say a number of the confounders are in there, right? You're free to go. Looks like we have enough. Like in our DAG, we've said these factors are going to make this a little messy. But if we have them and we've measured them, then we know with administrative data, it's never going to be the ideal. Now, if you don't have it, that means you can't meet some of these assumptions about causal inference. So should we talk about some of those assumptions? And then if you can't meet them, stop, don't try it. Ask a different question. Is that what you would say?
So I think this is a really good segue to the core assumptions. And you kind of implicitly gave one of them just now. We typically talk about three core assumptions in causal inference. And one of them, the most important one that applies whether you're using a causal inference method or not, it's whether you're trying to infer causation from data, is the no unmeasured confounding assumption. The idea that you've captured enough confounders that you're comfortable saying, I believe there's no unmeasured confounding. And that obviously, I think Hernan and Robbins in their book refer to that as a heroic assumption.
It's a huge assumption.
It's huge. And we make it all the time without sort of thinking about it. And I'll come back to the second part of your question about what do we do in the situation where we don't think that that assumption can be satisfied in our data. The second assumption of causal inference methods or inference methods that are based on this paradigm that I've been talking about today is they refer to as the consistency assumption. And consistency is a bad word for it. The better way to explain it, I think, is there are no multiple versions of treatment. So
that's really good.
What does that mean in words? If I'm comparing, take 10 milligrams of metformin, and I don't know if that's the right amount, once a day for the next 6 months, to inject a GLP-1 once a week for the next 6 months, those are very well-defined interventions. If I say breastfeed for the next 6 months, that's still a relatively well-defined intervention, because if I say don't give your baby any other food for the next 6 months, it's pretty well-defined. If I start talking about causal effect of a state, and so we often want to study, does obesity cause something?
Or gestational diabetes.
The problem with that is, does obesity cause gestational diabetes? The problem with that is that there are 10,000 ways to gain weight and lose weight. And you start running into the pathway between obesity and non-obesity matters, and you don't have this consistency unless you restrict it to say, take a GLP-1 versus don't take a GLP-1. There's one well-defined intervention that affects obesity. It's unclear whether we can infer that that's the causal effect of obesity itself versus the causal effect of GLP-1s, but at least it cleans that. Good news in pharmacoepidemiology is we don't have to worry too much about that, because we're typically talking about an intervention that's fairly well defined. Take this drug as indicated. is fairly well defined.
But if you're studying a chronic condition as the exposure, there could be 10 pathways to get there. So your consistency, and these terms are brutal. So at the end of this, I just want to summarize and try to connect them. But I like that. No multiple interventions. So if you're studying a complex exposure, it's going to be very challenging for you to infer causality, right?
Exactly. I think, if you talk about the effect of obesity or the effect of osteoarthritis or anything that's a chronic condition like that on something, then you're going to have a hard time. And I kind of want to take a little parenthesis here and say, it's not to say that obesity doesn't affect gestational diabetes or obesity doesn't cause gestational diabetes. It's that it's very hard for us to measure that effect using data that this assumption is raising the flag of. And Judea Pearl argues a lot that we can conceive of an effect of obesity or an effect of osteoarthritis. And he says that's fine. And I think that's probably okay to say we can conceive of that causal effect. The question is, if you want to measure it, and if you want to hang some statistical inference on it and say, this raises your risk by a hazard ratio or an odds ratio or a relative risk of 2, it's much harder to explain what that 2 means than to just say obesity in general does cause different outcomes.
I think Hernan talks about this a little bit, like we could cut off your legs and your weight would go down, and your BMI would go down, but the BMI is not the precise cause that we're looking at, right? It's
exactly. And somebody else, K.S. Joseph is a colleague of mine who is now at UBC, has always pointed out that smoking is a really effective weight loss drug.
Right. That's right.
And you may not want to consider GLP-1s, diet and exercise, amputation of your leg, and smoking as the same kind of intervention.
Right. So we talked about 2 assumptions so far. The first one, no unmeasured confounding, which I don't like this term, but exchangeability, is that the term used? Consistency.
Yeah, exchangeability. And their exchangeability is nice in some ways because the idea is if you take my 2 pregnant people at 14 weeks, the idea of exchangeability there, how it conceptualizes no unmeasured confounding is if you could switch them and have the one that was untreated be treated and the one that was treated be untreated and just exchange them, you should get the same answer.
Yeah.
And that kind of shows you what a big assumption that is too.
Yeah.
But I'm not sure it helps. Maybe it just makes things seem more intimidating.
Yeah. And in the pharmacoepi world, just one thing to add, like you would say there's no confounding by indication. Let's just, right? So that people are familiar with that term, let's say. And so you're making a huge assumption here, or you're saying we need to address this assumption. Maybe that's a better way to do it. There's an assumption that we need to address. So how are we going to address the fact that there could be unmeasured by confounding? We'll get back to that in a minute, but what's the third one before we go deeper?
So the third assumption, and this one is in my mind, not the easiest one, but it's the most transparent one. And I think it's really helpful in the framing of the problem is what I think is now mainly referred to as the positivity assumption. In some literature, it gets referred to as the experimental treatment assignment assumption. And the idea there is you want to have people in your study or subjects in your study who could have been exposed to the other treatment you're comparing. And so the example I always give in classes about this is if you knew someone had a penicillin allergy, first of all, you'd never enroll them in an RCT of penicillin. But if you knew in advance that the person had a penicillin allergy, you know that they have or they should have 0 chance of getting penicillin in a regular care setting. So that would violate the positivity assumption. You would want somebody who could get both treatments, and usually it comes up if they have a complete counterindication to one of the treatment arms.
So is this like a selection bias thing? Like, is this, would I put that in there?
Yeah, and it's a selection bias and a generalizability kind of thing where you want to clearly define the population who could be affected by this. And in pharmacoepidemiology, we worry sometimes about this because the most severe cases are typically treated exclusively with the most severe drugs, and the mildest cases are either untreated or treated only with the milder treatment. So in the mild cases, they violate positivity because they never would have been exposed to the heavy treatments. And the other tail, the ones who are really, really sick, would never be exposed to usual care or no treatment. So you try to just make sure that you've got comparable groups. And in Mike Kramer's breastfeeding study, they got around that by saying, if you came into the study saying, I absolutely intend not to breastfeed, then you would be excluded, because we know that no matter what we do, you're not going to breastfeed. And so you would violate that positivity assumption.
So this is like a massive challenge with administrative health data, right? So let's say I'm thinking about a gestational diabetes as an exposure. I'll compare everyone who didn't get gestational diabetes to everyone that got gestational diabetes. There's a cohort in there that didn't get it, that let's say are going to the Olympics this summer. Women who've trained their whole life, or the opposite end, women who are in their 70s. And now I'm comparing those two groups who, in theory, would never be exposed to gestational diabetes to a group that was exposed to gestational diabetes that's wildly different. And so there's a bit of a selection bias there, and we're not comparing apples to apples. On the gestational diabetes treatment arm, it would be your gestational diabetes is so mild, we don't have to worry about it too much. Or you actually have type 2 diabetes, and we misclassified it, and now we're treating you with insulin. So now we're going to compare insulin to nothing. And so now we're violating, because no one in the non-insulin group, so many women in the group that didn't get insulin, that would never even be considered for insulin because it would be dangerous to them.
Exactly. That's exactly the problem with this positivity assumption. And in the paper that we have coming out on levothyroxine, that is what caused us an enormous challenge and took what started with a gigantic database and reduced it down to this tiny, tiny number of people where you really thought you had a group that, say, at 14 weeks was treated and at 14 weeks wasn't treated, but could have been treated.
Right.
There were a lot of women in that database where they either didn't have subclinical hypothyroidism, or they had it and it was so mild that they were just not at risk to be treated at all. Or, like you said, the other tail where they absolutely had to be treated. There was no question that they would take the thyroid medication. So finding out who those comparable groups are, A, gives you a headache, B, forces you to contemplate leaving some of your sample out because they just don't have comparators that are relevant in your question. And then C, leads to, unfortunately, what look like wider confidence intervals, because they are wider confidence intervals because they maybe more accurately reflect the population that you could study on this specific question.
In my understanding of this, that is the most critical part of your whole project, is having the headache discussions about what is our target trial emulation? Like, what is our true sample of people who should be enrolled? Like, what's our inclusion criteria? What's our exclusion criteria? Because in the past, we would have said, let's just throw everyone in. Let's adjust for this. Let's adjust for that. And it'll wash out in the end. But in that case, you might get the totally wrong answer, which could completely flip clinical practice guidelines, right?
Exact. And this is probably the most important thing that I have learned over my career, going from, a statistician who would have gone about things exactly the way you described to where I am now, that we could spend a ton of time thinking about setting up the problem. And I know you've had conversations about DAGs, so conceptualizing what's the framework in which we're working. And I know you also had a conversation about descriptive data to say, okay, what do the people that I'm thinking about studying even look like? And both of those, I think, are part of this step towards, okay, really what's the question we're asking? And then how can we frame it in a way, and I like the target trial language to say, how can we frame it in a way that would reflect what we would have done? Could we have done an experiment? And then do we have data to mimic that experiment? And once we get there, this is not to say the analytic challenges have gone away, but the analyses can be relatively straightforward once we've got to that point of, okay, we feel like we've got the problem set up correctly. Yeah, so the headache conversation should come before we look at the data, or at least before we look at the associations in the data, rather than after we've got the results sitting in front of us.
Yeah. So we're coming up on time here, and I think we've done a beautiful kind of intro to this. If you're available, I would love to do a second one where we talk about what are some of these emerging methods that you could use in administrative data to try to say, we've addressed this assumption. We know this assumption is here. We obviously have unmeasured confounding, but here's how we've addressed it. But before we launch into that, you think,
sorry, go ahead.
Is that an interest of yours to maybe go into some of those methods?
Absolutely. I think we have a lot of tools that we can use for both setting up the problem well, and in administrative data, we have tools like the high dimensional propensity score, which try to do as good a job with confounding as we possibly can through using as much of the data as we possibly can. And then we have a bunch of tools for sensitivity analyses where we try to say, okay, I know that maybe in the gestational diabetes example we were talking about, I know I have very poor measurement of pre-pregnancy weight, which might be an important confounder of any number of things. Can I do sensitivity analyses to say, okay, how much might that have affected my problem? Usually that's not good news. It's like, okay, it's going to make my confidence intervals wider and maybe move my point estimate. But still, it's more reassuring than just saying, I didn't have data on pre-pregnancy obesity, so I didn't do anything about it.
I'm going to assume it wasn't there. Or if you're looking at a maternal exposure and an offspring outcome, we don't have genetic data. And we're just going to assume that doesn't matter.
Exactly.
Massive assumption. So just to maybe close this out, for residents and their supervisors coming in to see you, what's the top 3 homework items that they should be doing to make this conversation easier and to say, let's think about whether or not we could do some causal inference work here and emulate a trial, let's say?
So I would try to get people thinking about, really go back to the basics of the PICO, the population intervention control outcome, from this perspective of, if I were to do a trial or if I was thinking about a target trial, could I still set this up? And so that focuses in on really what's my exposure and what's my comparator, and could I think about a trial of those two things? And
like, who would I recruit into that trial?
Exactly. And could I recruit into that trial? I would start with that conversation and try to not think too hard about your data. Try to think about the question at the beginning. And then bearing in mind that you have to be realistic about what's in your data. You can't study, if you don't have genetic data, don't think about studying something that absolutely requires genetic data. But if you've got a typical drug safety kind of question that is plausibly addressable using administrative data, do the exercise of thinking hard about the PICO and the question from a target trial perspective. And then maybe we have our first conversation, and then maybe some descriptive statistics come out of the next step. And then we sort of converge towards, okay, this is actually doable, and we try to run a study.
Okay. Would we ask them to draw a DAG? Dig in a little bit to what some of those variables are that are going to make this messy?
I typically would, and I people phrase this part of the question differently. Some say draw a DAG, some say, list to me the 10 most important confounders of your association. In any case, that's a very important step, just to say what are the variables that might create this lack of exchangeability or this unmeasured confounding that we would worry about.
Great. Okay, that's perfect. I think that was a wonderful kind of intro. We didn't get into some messy language. I love that we defined positivity, exchangeability, and consistency in the right way, in an easy to understand way. And I look forward to doing the next deep dive on how do we address that using the data that we have. And then actually hearing a little bit more about what your experience is working with residents and some of the things that you could share with us to say, like, to make this relationship really work and to get the best out of the data that you're working with. Here are some of the things you've learned along the way, because I think I'd love to hear about that, and I'm sure a lot of our listeners would too.
Oh, that would be great.
So thank you so much for your time, and really looking forward to the next one. That was a wide-ranging discussion on the concept of causal epidemiology with Dr. Robert Platt. Be sure to join us for episode 10 in part 2, where we take a deeper dive into the assumptions and application of causal epi. Thanks for listening. The Emerging Scholar Podcast was recorded in the UMFM studios located at the University of Manitoba in Winnipeg, Manitoba, Canada. This is Treaty 1 territory, the original homeland of the Anishinaabe, the Innu, and on the national homeland of the Red River Métis. Manitoba is also homeland to the Anishinaabe, the Dakota Iote, and the Dene peoples. We acknowledge that our water is sourced from Shoal Lake 40 First Nation. As a settler scientist working in health research, I acknowledge TRC call to action number 18, that health inequities between Indigenous and non-Indigenous people are the direct result of colonization. Winnipeg is the Center for Reconciliation in Canada, and where we are speaking from today is at the crossroads of Canada's history and Canada's future. future. We are 3 kilometers away from one of the most sacred meeting grounds for Indigenous people on the plains and within Turtle Island. We are also several kilometers away from one of the last residential schools in the province. We are working collectively on reconciliation with youth, elders, and community leaders to heal from the trauma of colonization, past and present, honor the original treaties, and create a Canada that addresses and eliminates the inequities and injustices of the past and present to create a future for Indigenous children to live and thrive. On behalf of the team at the Emerging Scholar podcast, we want to thank Osani Balkaran for the great production for our opening and closing themes. We also want to thank UMFM 101.5, especially co-producer Jared McKediak for technical assistance and production on this project. We also want to thank all of our guests for the discussion and the insight that they've provided. Once again, thank you for listening. Be sure to subscribe to the Emerging Scholar podcast on Apple Podcasts, Spotify, and umfm.com.